Good morning. So coming to the second session of the day, injection techniques in oft-overlooked and oft-overlooked ace up your sleeve. I'm Dr. Pramod Bhor and this is Dr. Ashok Ghodke. We welcome our chairperson, Dr. Kiran Bhavnani today. So sir, please could you start with the session because we have a long session.
There are a total of 6 speakers and the first talk is by Dr. Anisha Valavi. She's going to speak on common conditions in the knee treated with injections.
Good morning, everyone. I'm Dr. Anisha. I'm going to talk on common conditions in knee treated with local injection. So as we all know, globally there has been an exponential rise in the prevalence of knee osteoarthritis, and it has already affected 31% of Indian population, with a prevalence of osteoarthritis being more than 70% in population of 60 plus age group, and also 34% of people among them are already suffering from a chronic OA related joint pain. Similar things have been noticed in the Western countries where the burden forms about 80% of the total disease burden, and 19% of the American adults age 45 and older are also involved in this. So, and also the knee osteoarthritis incidence has doubled, prevalence has doubled since the mid 20th century. So much so that in 2017-18, there were 54 million people in the US alone affected, and they are and it's been projected to be 78 million of the population being affected by 2040. Also, as the age increases, the prevalence increases up to, as we have already said, talked about it, as in 70%, with women being maximally affected in the older age groups. The other inflammatory conditions around the knee are like the rheumatoid arthritis, seronegative spondyloarthropathies, crystal-induced arthropathies like gout, pseudo-gout, prepatellar and pes anserine bursitis. And you also have to rule out, when you're treating these conditions, you have to rule out conditions like fibromyalgia, disc prolapse, radiculopathy, spinal injury, cancer, post-surgery conditions. So what are the treatment options available in these patients who come to the OPD with knee pain? So initially, as we all know, we treat them with oral medicines, as in paracetamol being the commonest, unless the patient is having any liver issues. Then comes the NSAIDs, but also they have low to moderate risk of side effects, as we see here. And also topical NSAIDs help. And we tend not to, we have been grown out of the use of opiates over the past so many decades. And other things are like physiotherapy load management. This topic is related to knee injections, of which we are going to talk in the next half. So we are looking to the short-term pain benefits, long-term pain benefits, and long-term structural changes in these patients, and the risk of avoiding the risk of knee replacement. So what are the, why intra-articular injections, and is it a definitive treatment in these population? So intra-articular injections, the goal of the intra-articular injection is to reduce pain and swelling, improve function and quality of life, limit disease progression. However, this is not a definitive treatment at all and is preferred as a last non-operative modality after exhausting and concluding that the other conservative treatment modalities are ineffective, like NSAIDs, physiotherapy, weight reduction. The substances used in intra-articular injections are, as we all know, corticosteroids, intra-articular hyaluronic acid injections, and the intra-articular platelet-rich plasma, which has been recently in the WHO. So the current literature indicates that intra-articular injections are safe and have positive effects for patient satisfaction, but there is no data that any of the intra-articular injection will cause osteophyte to regress or cartilage and meniscus to regenerate in patients with substantial and irreversible bone and cartilage damage. So talking about the corticosteroids, there are 5 FDA-approved drugs that have been used over the decades. The methylprednisolone acetate, betamethasone acetate, and betamethasone sodium phosphate, dexamethasone, triamcinolone acetonide, and triamcinolone hexacetonide. So the mechanism of action of these corticosteroids, as we all know, is anti-inflammatory and immunosuppressive effect, which directly act on nuclear steroid receptors and interrupt the inflammatory and immune cascade, reducing the vascular permeability, inhibiting the accumulation of inflammatory cells, phagocytosis, production of neutrophil superoxide, metalloprotease, and so on, and prevent the synthesis of secretion of several inflammatory mediators like prostaglandin and leukotrienes. The effect is seen like in reduction in the erythema, swelling, heat, and tenderness of the inflamed joints, and improved in the mobility of the joints. So, the indications for corticosteroid use is to treat acute and chronic inflammatory conditions which are not amenable to NSAIDs, physiotherapy, and weight reduction, and especially during the osteoarthritis flare where there is evidence of inflammation, chondrolysis, and joint effusion, and high-risk patients whose TK surgery have been deferred, patients who are having fear of surgery, and however, the use of intra-articular steroid lacks the evidence for efficacy in functional improvement like stiffness, walking distance, quality of life at any point of these injections. Contraindications for the intra-articular steroids are diabetes, overlying cellulitis, septic effusion, existing coagulopathies, and the common side effects known of these are the pain and swelling, skin discoloration at the site of injection, elevated blood sugar. So
Yeah, you carry on for 1 more minute.
And allergic reaction to corticosteroids. So the other injectable that has been commonly used is the viscosupplementation, that is a hyaluronic acid injection. It's been produced by the harvested rooster combs and bacterial fermentation. The commonly used HAI injections are sodium hyaluronate, Hylan GF20, and high molecular weight hyaluronate. These injections are scheduled in various forms from minimum of 1 injection to 5 injections depending on the molecular weight of the product used, and it can be repeated after 6 months of the initial injection if the patient is satisfied with the last injection. And comparative clinical studies have proven that the efficacy of high molecular weight hyaluronic acid with respect is better for disease-modifying effects of the ONE. So the mechanism is it enhances the viscosity and elastic nature of the synovial fluid, adding to the acting as a viscous lubricant and elastic shock absorber. Viscous lubricant in slow joint movement and elastic shock absorber in rapid joint movements, and reduces stress and friction on the cartilage. It also acts as a backbone for the proteoglycans of the extracellular matrix. And it restores, so the injections, it restores the normal viscoelastic properties and restores the lubricating and shock absorbing effects. And
yeah, I think you can tell us the bottom line.
It's Veena, sorry, it's Veena. The other type of injection that we all know is the platelet-rich plasma. It's made from the autologous blood by centrifugation to obtain a highly concentrated sample of platelets, which is 4 to 5 times higher than that of the normal blood. Normally, we have 2.5 lakh platelet count in the normal aspirate. After centrifugation, it gets concentrated to 10 to 40 lakh. So with such high concentration of the platelet, it is a high source for active molecules like growth factors like insulin-like growth factor, TGF-beta, PDGF, and active molecules like cytokines, chemokines, arachidonic acid, etc. And it has been proven to be a factor that has a role in chondrogenesis, bone remodeling, proliferation, angiogenesis, and anti-inflammation, and coagulation and cell differentiation. And it is usually given in 3 sets of PRP injections, either 3 to 4 weeks apart. It has shown good results in young individuals below 50 years of age if the osteoarthritis is of grade 1 to 3 below 50 years, it is proven that platelet-rich plasma is more effective compared to hyaluronic acid. However, if the patient is beyond 50 years of age, it is better that the patient receives intra-articular corticosteroid if it is an acute osteoarthritis flare. And so there have been studies, numerous studies for the same, suggesting that PRP is more effective than hyaluronic acid and steroid in randomized controlled trials. And at 4 weeks, 2 to 4 weeks, corticosteroids have the maximum effect, showing that it has very good short-term relief.
Can you please
in pain.
summarize? Please.
Yes, sir.
Please.
I'll just go. So the injection technique, the topic was changed, sorry. So there are multiple injection techniques. That is the anterolateral approach, the lateral retropatellar approach, medial retropatellar approach, suprapatellar approach. And to summarize, choose the intra-articular supplement wisely. Long-term benefits of injectable PRP are superior than hyaluronic acid in mild to moderate OA knee, especially in Kelgan-Lawrence grade 1 to 3. Injection PRP has shown better results in young individuals than injection hyaluronic acid. Use of steroids should be cautious. It should only be used in acute and severe flare-ups in osteoarthritis and inflammatory arthritis, or to bridge the gap till surgery. The gap between the surgery and the steroid injection should be minimum of 2 to 3 months. And or to give it in high-risk patients whose surgeries have been deferred or have fear of surgery. And it's reserved mostly for the higher grade or acute flare-ups. So, and maximum 2 to 3 shots of steroids is the limit. So that's it. All right, thank you so much.
Thank you. Yeah, our next speaker is Dr. Chintan Desai. He's going to speak on shoulder pain fixed with injections.
Thank you so much for having me here. My topic is about the techniques of shoulder injections and shoulder pain fixed with shoulder injections. All right. So my indications for shoulder injections are mainly for post-op pain management. We all know rotator cuff repairs are very painful post-op, or can be. So we want to minimize the post-op pain of that patient. Now we all know that the book should not be judged by the cover, but most often it is. So no matter how good your surgery is, if the patient wakes up in pain, that's not ideal. So you want to fix that. The other outpatient department treatments for shoulder pain which require injection, in my opinion, are bursitis, adhesive capsulitis, partial tears which are less than 50% thickness or low-grade partial thickness tears, tendinitis or calcific tendinitis, impingement syndrome, spinoglenoid knot cyst, and AC joint pain. I generally tend to avoid giving injection in full thickness tears or high-grade partial thickness tears, and we will see why. So post-op pain relief, our anesthetists are brilliant at doing this. Brachial block injections are quite effective and very effective in reducing the post-op immediate pain. The analgesic effect of just using 0.25 sensocaine as a brachial block, the effect would last for 6 to 8 hours. There are some additives that you can use, either with dexamethasone given IV or mixed in the cocktail, can prolong that effect for a few more hours, so 8 to 12 hours. If you add clonidine, that's going to give you a pain relief for about 24 hours. So, all these additives can be added depending upon how much post-op pain you are anticipating and your patients wake up in comfort. Avoiding these injections, there are some contraindications or relative contraindications. If you are expecting a nerve injury, or if you think there is going to be a brachial plexus stretch, or if you are preoperatively anticipating nerve injuries, giving a brachial block is going to prevent you from seeing any post-operative movements. So analgesia is preferred, anesthesia tend to avoid. We have ropivacaine also available now, so we can use ropivacaine 0.75. That is only going to give us analgesia and not anesthesia. So if you use that, that's good. Several techniques of access to the brachial plexus have been described, interscalene blocks being the most common, supraclavicular, vertical infraclavicular, and axillary nerve or axillary approach to access the plexus. What I use and my anesthetists use is interscalene block. We can, as orthopedic surgeons, learn to do this ourselves as well. And this is quite important, let's say, on field as well. Let's say if somebody had a bad injury and was in a lot of pain, we could give that on roadside as well. So interscalene blocks like this, where you can mark out the sternocleidomastoid and just lateral to the clavicular head, you'll see the interscalene groove, and that's where you enter and inject. You could use a nerve stimulator to be more specific, and ultrasound guided injections are now the norm in our ORs. So once we use this, we can access the brachial plexus quite well. We can see those sister nerves and block around them, and that's quite effective. Supraclavicular and axillary nerve blocks. Now, let's face it, sometimes the anesthetists take longer to find the nerves than our surgeries do. So in those patients, if your turnover time is affected, then what we recommend, or what I do generally in those compromised situations, is I prefer to use suprascapular nerve blocks and axillary nerve blocks, giving me good post-op pain relief. So when you mark out your portals or the acromion and the inner border of the clavicle and acromion, and if you go from the Nevasia portal, so that's the Nevasia portal, you directly hit the suprascapular fossa, and that's where the suprascapular nerve is, and you inject there with Sensacaine 0.25, about 10 cc, and that's going to block your suprascapular nerve. That's very easy to do. You could do it yourself, and about 3 finger breadths down posteriorly to the insertion of the deltoid is where you inject in that space, and that's going to give you a good axillary nerve block. So these patients will wake up with good comfort, and these are very simple treatments or procedures you could use in your practice to help your patients wake up in pain-free. Outpatient procedures, I prefer to do USG guided injections for bursitis and impingement. I use 2% lignocaine and 40 milligrams triamcinolone, and that allows me a good access. I know there's a talk about the benefits of USG, and I'm sure this will show the effects. Now, when we are able to locate very well the bursa in this patient, we can see the bursa blowing up when you inject over there. That's going to create a good space in the subacromial space, and you see the impingement sort of disappearing. Now, there are several studies that say that unguided blocks versus guided injections or USG guided injection, not much post-op difference, but I think that's just because of the effect of the medication. I mean, the steroid is going to be effective only in that much period of time. Intra-articular injection techniques, we can use in adhesive capsulitis especially. You can use this because the inflammation is intra-articular in the capsule. You can access it through the anterior side, just lateral to the coracoid process, or just from a posterior, from a posterior portal where we insert a scope. That's exactly where you can put your needle in and go and access the capsule. You inject there with a steroid, and those patients are quite good. Now, these are some randomized control studies I have just showed, because there is an increased use of platelet-rich plasma and modalities like this to treat shoulder pain. In my opinion, I don't use them because I don't see that much benefit, especially cost benefit. And these randomized control studies say the same, that short-term or long-term results of steroids versus PRPs is nearly the same. So I stick to the basics and continue to give steroids in these patients. Prolotherapy is something which is also described as a high concentrated glucose solution which is induced or introduced to create some scarring. And that as well in a randomized control study is showing that there are similar results to steroids. So I still follow the same. Giving steroid injections in partial thickness tears, beware that in this study, 17% patients have progressed onto full thickness tears beyond giving a steroid. So is that going to cause weakness of a rotator cuff muscle? Still questionable, but we have some evidence that some patients do progress to full thickness tears. This was a very interesting study. Do corticosteroid injection compromise rotator cuff tendon healing after arthroscopic repair? This is an everyday thing for us, for me at least, and it was an interesting finding that they found that pre-operative corticosteroid injections given actually do not cause any increased rate of re-tears. However, post-operative, if you've given a steroid injection after a rotator cuff repair, let's say your patient is stiff or not improving, those patients actually had a higher re-tear rate. Now, there is a discussion in this study as well saying that maybe those patients are already doing poorly, which is why they did not improve, which is why steroid was given. Was that really a risk factor? don't know, but that is still some anecdotal evidence to say. Anyway, thank you. I hope I did justice to the topic. Thank you for your attention.
Thank you, Dr. Desai. Just a small request, if we can stick to the time, I think we are exceeding our time. The next speaker is Dr. Amit Supe. He's going to speak on ace up your sleeve to get rid of elbow pain with injections.
Ace up your sleeves, Mohd Faisal. Yeah. Good morning all. I will be presenting ace up your sleeves to get rid of elbow pain with injections. So the indications for injections around elbow are pain because of arthritis, in lateral epicondylitis, medial epicondylitis, olecranon bursitis, or distal biceps tendinopathy. So in arthritis of elbow, we can always see there is reduction in the joint space. In elbow anatomy, the elbow joint formed by the radiocapitular as well as ulnohumeral joint and the stability provided by the soft tissues, tendon and ligaments. Intra-articular elbow injections are given in rheumatoid arthritis, osteoarthritis, crystal arthropathy. The injections should be only considered with the appropriate therapeutic interventions for rheumatoid arthritis or osteoarthritis or crystal arthropathy. These are the equipments and the pharmaceuticals for the injection of the elbow joints. For elbow joint aspiration, we usually need 18 gauge needle, and for the olecranon bursitis aspiration also, we will require a wide bore needle of 18 or 22 gauge, while for the elbow joint injection or in epicondylitis or bursitis, we require 25 gauge needle along with the anesthetic agents of 3 to 5 ml of 1% lidocaine or bupivacaine, along with the corticosteroids of 1 to 2 ml of betamethasone or 1 to 2 ml of methylprednisolone. So the technique for elbow joint aspiration, we need to pass the needle through the triangle formed by the lateral epicondyle, radial head and the olecranon. The needle should be directed towards the medial epicondyle. Patient should be in the supine position with elbow flexed to 45 degrees and forearm in the neutral position resting on the thigh of the patient. The follow-up care should be patient should keep in the supine position for 1 to 2 minutes after injection. Check for the passive ROM to determine pain relief. Patient should be monitored for at least 30 minutes for any adverse reactions. Patient should avoid any strenuous exercise for 48 hours following injection. If there are steroid flares, they should be treated with the ice and NSAIDs, and follow-up should be done within 3 weeks. For medial and lateral epicondylitis, the lateral epicondyle, we know it is the origin of the extensor supinator muscle group, while the medial epicondyle is the origin of the flexor pronator muscle group. The epicondylitis, as it suggests the name, inflammation, but it is not an inflammation, it is a chronic degenerative process of tendons at the respective epicondyles. Clinically, it can occur because of the repetitive activities such as golf, which can cause medial epicondylitis, playing more tennis can cause lateral epicondylitis, throwing sports and hammering. Patient will have tenderness, pain and weakened hand grip. And weakness is exacerbated by resisted wrist extension and supination for lateral epicondylitis, which is Mills sign, while resisted wrist flexion and pronation for medial epicondylitis. So indications of injection are chronic pain and functional disability and acute severe pain with the functional impairment. Therapeutic injections for epicondylitis should be performed only after trial of other therapeutic modalities such as use of NSAIDs and avoiding aggravating activities. For lateral epicondylitis, the affected arm should be placed at the side with wrist pronated and elbow flexed to 45 degrees. The needle should be inserted to the level of bone at 90-degree angle and pull back 1 to 2 mm. The point of maximum tenderness should be addressed. For medial epicondylitis, the arm should be abducted, elbow extended, and the hand should be supinated as the injection is administered. The elbow should always be extended for medial epicondylitis because it may cause the iatrogenic ulnar palsy. For preparation and techniques, steroid and local injections can be given. We can also use the papering techniques in which we inject, then withdraw, then again redirect the needle without pulling it out of the skin, then again inject, again withdraw, again rehydrate till the grating sensation in the tendon is lost. Dry needling and autologous blood transfusion can be given. Platelet-rich plasma or botulinum toxin can be given. Botulinum toxin causes the digit paralysis. This is a study where the hyaluronic acid injections for chronic tennis elbow were given in 18 patients, where 2 cc of hyaluronic acid was given at the site of the maximum tenderness, where 3 injections were given 2 weeks apart. In this study, the authors got improvement in quick dash, was and patient rate tennis elbow evaluation scores in 3 months and improved pain scores in the hand grip. In this study, the platelet-rich plasma was given for the medial epicondylitis in 15 patients, and the authors got good results in full ROM and Mayo performance scores. This is a study where the local injections were given in 120 patients. In 60 patients, 1 ml of lidocaine was given, while in the 60 patients, 1 ml of lidocaine along with triamcinolone was given using the papering technique. The steroids were having the short-term effect, and excellent results were obtained in the both groups using the Verhar's criteria. In follow-up, patients' extensors and flexors should be stressed. Then the next entity is the olecranon bursitis. Olecranon bursa is extra-articular and superficial to the olecranon process, and olecranon bursitis commonly occurs after repetitive trauma to the elbow, rheumatoid arthritis and crystalline arthritis. Clinically, there will be swollen red fluid-filled sac. It is relatively painless. In acute conditions, we need to only aspirate, while in the chronic condition, corticosteroid injection can be given. Staphylococcus aureus infection is commonly seen, and in such conditions, we should avoid the steroids. In supine position and with elbow flexed, we have to palpate the olecranon sac and the needle should be directly inserted. Pressure dressing should be given once the aspiration and injection is done. Then in distal biceps tendinopathy, it has a spectrum which include bicipitoradial bursitis, chronic tendon degeneration, distal biceps partial tear, and distal biceps complete tear. A patient may have pain and tenderness and reduced flexion and supination strength. In this study, using the sonography in 12 patients, the injections of steroid were given, 2 milligram of ropivacaine, 40 milligram of triamcinolone and 1 ml of normal saline, and improved VAS scores at the 6 months. The complications of the injections can be skin and soft tissue atrophy, lipodystrophy, loss of hairs, depigmentation or hyperpigmentation, steroid flare-up reaction, septic arthritis, and systemic effects which are very rare, like Cushing syndrome. Thank you.
Thank you.
Thank you.
Our next speaker, injections in the hand, Dr. Ashok Ghodke.
Thank you. So, some injection techniques. Today we will present common conditions like ganglion, trigger finger, decurvance, carpal tunnel syndrome, TFCC, dipitans, and acute cervical disc. So we straight away go with some video presentation. This is a ganglion case, 35 female, swelling since 3 months. So this is the way we first palpate and see if it is fixed, and at the point of entry, we give local anesthesia first, and then this is the solution, local anesthetic with Kinacort with some normal saline. So the idea is we don't aspirate the ganglion fluid. We should go inside and push in so that the ganglion bursts. So this is the procedure. So here the injection, it is injected into the ganglion, and we give some gentle pressure and spread that and this is the way the ganglion is treated. So many times, this is another case where the ganglion is in the base of the ring finger, and again almost the same technique, the injection, local anesthetic with steroid, it is injected, and so the recurrence rate we have seen is very less. This is another case where trigger finger, she is a 58-year-old female, complains since 2 months, and so this is sort of severe type of trigger finger where we have to use other hand to reduce it, and again we mark the A1 pulley, and the point of entry we use local anesthetic, so that the wide bore needle which we use for steroid injection, it is sort of painless. Decurvance, 28 female, postpartum 6 months. Usually they say that this postpartum decurvance, it resolves of its own, but here she was having pain. This is Finkelstein's test positive, and we can see this. And again we do marking. So at the tip of radial styloid, 1 centimeter proximal is the extensor tendon, retinaculum. So there we inject local anesthetic, and okay. So TFCC pain, this is the foveal sign positive on the left side, and we do ballotment. Ballotment is also positive. So again we do the marking. Marking is done, and we see the foveal, the point of entry over there. Some local steroid is given, and further we give this steroid along with local anesthetic. So very, very common presentations in OPD, TFCC injuries. This is a case of bilateral carpal tunnel syndrome, left more than right, in a 40-year-old female. So some confirmation with the provocative tests. So this is reverse phalanx test, and we mark the point of entry. So we flex the ring finger wherever it touches, that is the point of entry, and this point to this point is the transverse carpal ligament. And it is always mandatory whenever we are using local anesthetic to do a skin test. So we do this, a subcutaneous local anesthetic, and once we give that, we do a marking and write timing over there. So this is very important, because even though if we get any reaction, adverse reaction, so this is at the point of entry, we give some local anesthetic, and this injection we do prefer using ultrasound guidance. So we have a lecture, next lecture is with that. So this is for the carpal tunnel syndrome. Dupuytren's, this is 50-year-old male, left side it is moderate, right severe. So severe right side we operated, and left side we did this needle fasciectomy. So this way we go inside and do the fasciectomy. So this is for the Dupuytren's contracture. This is a very special situation, like acute cervical disc with severe radicular pain, and the patient came with hand above the head. It was so painful. So this is the point where we give this combination of injection, like the local anesthetic with Kinacort, with clonidine, and we can see some dramatic results. The patient has very satisfactory results with this. So this is an acute cervical disc where we inject in this first web space at the base of second metacarpal. So dramatic relief after that for acute cervical disc with severe radiculopathy. So these are techniques for common conditions with easy solutions, with a fast learning curve and a great relief for patients. Thank you.
Thank you, Dr. Ashok. Our next speaker is USG, Dr. Ankit Shah, who is going to speak on USG. Is it a useful guide for giving injections?
All right. Good morning, everyone. So, thank you so much for the invitation. So, I'll be talking on ultrasound-guided musculoskeletal injections. So, the learning objectives are to identify or learn what are the needs for ultrasound guidance for doing your injection procedures. See how we can visualize a needle better on ultrasound and what are the common applications. So why bother with ultrasound guidance, all right? So we've been already doing it so well for so many years using landmark guided techniques, so why ultrasound? For the simple reason is that ultrasound guided injections have better accuracy compared to landmark guided injections. And it's not just me saying that, and there's tons of literature supporting this, whatever I say. It's just that, nowadays, if you're using more expensive, injectates like PRP or stem cells, you want to make sure that you get it at the right place so that the patient has the maximum benefit for that. So ultrasound becomes really important when the anatomical landmarks are obscured, especially if the patient is obese in the post-operative settings, if there are any anatomical variations. So ultrasound can really help you identify the site that which you want to inject, and it's going to make your life much more easier. So this is how you visualize the needle. This is the most common way. The needle is parallel to the probe. That's how you go, and you'll be able to see the entire length of the needle and the in-plane technique. That's what we call. And this is a slightly less popular technique, which is known as an out-of-plane technique, where the needle is 90 degrees to the ultrasound probe, and typically the probe cuts the needle. So you'll be seeing the needle as a dot. So we use it less commonly, maybe in more superficial structures, like, if you want to inject the ankle, or maybe you want to inject the scapholunate ligament, that's where this can be useful, but most of the time we'll be using this in-plane technique. And so let's say we are trying to inject for a trigger finger. This is what an in-plane technique would look like. You look at the probe, and that's the position of the needle, whereas an out-plane technique, you keep the probe in a horizontal fashion and you insert the needle, which is almost 90 degrees to the probe position. So in plane technique, you will be seeing the needle come in along the entire length, and you'll be seeing the tip all the while. Whereas in out plane technique, what happens is, while you're seeing the needle, you have to be very careful, because by the time you see the dot over here, the needle tip must have already progressed distally. So this you got to be really careful, and this is the technique that we use most commonly. Try and keep the needle as parallel to the probe as possible, because the more parallel the needle to the probe, the more well visualized the needle will be, because if it goes more than 45 degrees, the visualization of the needle becomes a little bit more difficult. So plan your procedures accordingly. So the general principles are that whenever we are injecting around the tendons and the nerves, we see the tendons and the nerves in the cross section. That means they are seen as rounded structures. All right. So this is the de Quervain's injection for de Quervain's tenosynovitis. You see the compartment 1 tendons as rounded structures, and this is the injectate. That's the needle. And this is a patient with carpal tunnel syndrome, where we see the median nerve as a rounded structure, and the needle is either goes from medial to lateral or from lateral to medial, so that you can inject around the nerve superior as well as inferior to the nerve. As far as joints is concerned, there's no one particular technique. So this is one patient with frozen shoulder, where we see that the needle goes, that's the glenohumeral joint, that's the long axis of the needle. This is once we enter the joint, you see the injectate flowing right over here. All right, so joint, whichever is the best position of the visualized joint cavity, that's what we follow. And we typically go from lateral to medial from the posterior approach. So there are 3 common clinical scenarios where we can use ultrasound guided injections. One is purely therapeutic scenario where you want to do some kind of a therapy for the patient. So this is one 37-year-old female with de Quervain's tenosynovitis. That's the radial styloid, and that's the thickened extensor retinaculum, and that's the compartment 1 tendon. Now over here, what we see is this compartment 1, you have isolated involvement of the EPB, so you have an accessory septum over here. So as my needle goes from the radial from dorsal to volar, what I do is I inject over here around the EPB. But if I want to inject around the APL as well, what I need to do is I will have to go through the septum over here and go through that. So this was a patient with rheumatoid arthritis. We go from medial to lateral, and that's what we see, the injectate over here in the distal radioulnar joint. And this was a patient with plantar fasciitis. That's the position of the probe, and this is how I would go from medial to lateral. That's the position of the needle. I would not want to inject over the inside the plantar fascia, but right on the surface. So this was a patient with greater trochanteric pain syndrome. You would want to inject in the greater trochanteric bursa, especially it becomes useful when the patient has large amounts of body fat. This was a patient with Morton's neuroma over here. So you would want to inject in the intermetatarsal bursa. So this is the needle, and this is the amount of injectate which is flowing right in over here within the bursa and distending it. So this is a second scenario where you have therapeutic and diagnostic.
We are running out of time. We have one more speaker.
Yes, all right. I'll just skip this. So this was one 74-year-old with ankle pain, operated 7 years ago. You want to make sure what is the cause of the pain. So that's when in the post-operative setting, you can inject within the joint right over here. So I'm just going to skip some of these, and ultrasound-guided injections can be done before or after a therapeutic procedure. For instance, a patient with a trimalleolar fracture, they could not get the appropriate reduction because of pain. You just inject within the joint when all your anatomical landmarks are distorted. And this was the presentation. This was closed reduction with blind local anesthesia. They couldn't get it. And this is what we got with ultrasound-guided local anesthesia. And this is just the last case under calcific tendinosis. So after we've aspirated the calcium, what we do is this is the aspirate, and then what we do is under ultrasound-guided inject within the subacromial subdeltoid bursa. So the take-home message is ultrasound-guided injections are remarkably accurate, they're safer, and they allow better decision-making. So if you're in a spot while doing some kind of a procedure, do not shy away from using ultrasound for your procedure. So thank you so much.
Thank you, Dr. Shah. The next speaker is Dr. Pramod Bhor. And probably we are running out of time, so we'll just finish this off in about 4 minutes.
Yeah, try to finish in 3. So coming down to the paradigm shift of management of osteoarthritis with Triamcinolone Hexacetonide. So basically, how do we manage osteoarthritis? There is a 2021 article from American Academy of AOS saying that we should manage with analgesics first, and if possible give intra-articular steroids, which can be used for better and longer this thing for around 3 months. So what is the need for intra-articular glucocorticoids? So we have been using glucocorticoids, methylprednisolone, triamcinolone acetamide. So the duration of action of methylprednisolone is 7 days, intermediate, and 14 days, which is a long-acting, that is triamcinolone acetamide. The mean residence time of triamcinolone acetamide, that is TA, is 3.1 days. Due to the short mean residual time, the duration of action is 7 to 14 days, and that is why repeated injections are needed. That is approximately for every 3 months. So repeated injections causes septic arthritis, post-injection increases the inflammation, joint damage, and etc. So that is the need for change of injections. So need for intra-articular glucocorticoids. So rapid pain relief, whenever there is an acute case, definitely you require to go ahead and give an intra-articular steroid. Increased intra-articular steroid with increased mean residence time is needed, and long-term response should be needed. So whenever you require to use an intra-articular steroid, it should see that it is giving a long-term effect. So triamcinolone hexacetonide, basically it is a long-acting injection. It is a long for about large joints around 1 ml, that is 10 to 20 mg of injection is needed. Medium-sized joints around 10 mg, smaller joints around 2 to 6 milligram, that is 0.1 to 3.3 ml. Indications is osteoarthritis, sometimes in post-traumatic, rheumatoid, juvenile, or idiopathic, synovitis, tendinitis, etc. So basically, the duration, the onset of action is 24 hours. Within 24 hours, it is an anti-inflammatory if activity, no mineralocorticoid infection active effect, so lesser side effects. So the difference between the other this thing is that systemic absorption is around 35 to 40% with a triamcinolone hexacetonide, whereas in 58 to 67% with TA and the other with 78% or more. So lesser side effects, lesser systemic exposure, longer duration of action. This is basically because of the lower solubility rate, solubility of the triamcinolone hexacetonide. So synthetic glucocorticoid with pronounced anti-inflammatory activity, almost insoluble in water, and therefore dissolution and dispersion in the tissue at the injection site is generally slow, takes few weeks to several months. Anti-inflammatory potency is approximately 5 times that of hydrocortisone. Triamcinolone has practically no mineralocorticoid effect, therefore no sodium retention, relatively safe in cardiovascular and renal patients. So coming down to clinical relevance, it has a greater reduction in the VAS compared to placebo. There are many studies done on that. Secondly, coming down, THA has provided short-term relief in pain of relief of OA. Increased benefit is associated with both clinical evidence of joint effusion as well as successful aspiration of synovial fluid. So basically, recommendation is to aspirate the synovial fluid pre-op before giving the injection. So there have been studies, clinical relevance, evidence supporting the rapid pain reduction of triamcinolone aspirate. So it suppresses the HPA axis as compared to the methylprednisolone, therefore offering more safety. Adrenal suppression and everything is less as compared to, that is why it is more less systemically, has less systemic side effects. The rate of absorption and duration of action is more, so that is why it is faster in, and longer duration. So there have been many clinical studies done, clinical evidence supporting long-term sustainable response of triamcinolone over 24 weeks. So there have been studies done along with methylprednisolone. There are the study groups have been patients with knee osteoarthritis with ACR criteria with failure of symptoms to control with NSAIDs and analgesics. VAS score of more than 40 mm, age more than 40. Exclusions is rheumatic and or inflammatory conditions, symptomatic disease with lower limb, etc. So it has showed improvement in pain and function can be sustained up to 24 weeks. Similarly, for bilateral ONE, similar exclusion and inclusion criteria have been used. Efficacy peaks at 2 weeks after injection and effects continue and long term until the 24th week. The dosing of knee synovitis in chronic polyarthritis, this study was done. The proportion of relapse of after 6 months was equal to 20 mg or 40 mg, and no significant difference was found in patients with rheumatoid or psoriatic arthritis. So, summary. So, triamcinolone hexacetonide is comparable in efficacy to the current available intracorticular corticosteroid. It scores above others, absorbs slower than currently available intraarticular corticosteroid, thus creating lower systemic corticosteroid levels. Suppresses the HPA axis as compared to methylprednisolone and prednisolone, thereby offering safety, more safety, better intraarticular duration of action as compared to methylprednisolone and triamcinolone acetamide. THA is less soluble than methylprednisolone and triamcinolone acetamide within the synovial fluid, thus increasing the mean duration of action within the synovial joint. So basically, it's a long-acting corticosteroid that has been used. Thank you.